if tubal removal is the only option, what is the reason for removing the tube? Does it cause
Okay.
concerns later on?
So, one, as far as blocked tubes, it depends on why your tubes are blocked. So, the first thing, if you do an HSG, so an HSG, that's a hysterosalpingogram. That's the dye test where we want to see the uterus is a pretty triangle, dye comes out, goes into the uterus, spills all over the pelvis. That's what we want to see. So if we do that test and we don't see that, where is the tube blocked at? The tube is blocked, we call it proximally, which means like you see this pretty little triangle and you see nothing come out. Well, then that could just be a tubal spasm. Maybe both of your tubes spasm and they're both open, they're fine. And so maybe we just need to repeat the HSG. So generally, when I see that, I will order what's called a tubal cannulation. It's an HSG with cannulation. It's something that's done by the interventional radiologist. Actually, the REI doesn't do it, or this REI doesn't do it. And so I don't want to speak for everybody.
Yeah.
And so basically what happens is it's just like doing a heart cath. The radiologist, they do the dye, and they'll put the dye through to see if the tubes are blocked. And sometimes they're like, yeah, we did our HSG, was completely normal. And that's because the tubes had a spasm before. But basically what they do is they take a guide wire that's the same guide wire that they would use to like unblock like a carotid artery in your heart, and they put it through your tube. The thing is honestly, like that's going to work. 50% of the time it's going to work. 50% of the time it's not going to work. But usually if someone has a blocked tube that's kind of what I call in the early part of the tube, I'm more than willing to go ahead and try that. And I'm willing to try it in the distal end as well, but usually when the distal or the long ends away from the uterus are blocked, part of the issue is usually there can be some scarring, and so that's kind of the issue there. But when it's up earlier, it could be a mucus plug, it could just be old cells or debris or things like that. First thing is a cannulation. Now, if the tube is blocked, and the fluid is doing what it's called building up, something we call a hydrosalpinx, which is a fluid hydro and salpinx tube, fluid-filled tube. Now, if it's a hydrosalpinx, then that tube needs to be removed. Why? That tube needs to be removed because it has fluid in it. And there was a study that they did. They randomized women who were going to do IVF that had a hydrosalpinx. They randomized them to doing IVF and an embryo transfer with that hydrosalpinx in place versus doing IVF after taking that hydrosalpinx out. What they saw was the people who had their hydrosalpinx removed, their success rate, because it was a little while ago, I want to say was roughly around like maybe 40%. And the people who didn't have it removed, their success rate was 20%. So it's like a land-breaking study. Every REI knows this study. And that is the reason why. And so what they said was basically, if you have a woman who's doing IVF, who has a hydro in place, if you want to double her chances of pregnancy, you need to remove that tube. Now, then there's the why. So the why is there's fluid in there. And the truth is we don't know the why. The why is maybe because that fluid in there, what I tell my patients is, I don't know, that fluid, maybe it's toxic to the embryo. Maybe it has substances in it because it's not getting out that is toxic to the embryo. Or maybe it's like a big fluid wave that comes in and it washes the embryo out and it just surfs right on out the cervix. Maybe that's what's happening. I don't think that we exactly know, but we know that was a landmark study. And so for me, if you come to me and you have a hydrosalpinx, whether you're doing IUI, whether you want to do an OI, whether you're just trying to have, timed intercourse at home, or you're doing IVF, I'm going to tell you we need to remove the hydrosalpinx because that is going to increase your chances of pregnancy. The pushback I get from patients is, well, if you take my tube away, then you're decreasing my chances of pregnancy. And that's not the case. Having that tube that's damaged with fluid in it, that's already decreasing your chances of pregnancy. I'm actually increasing your chances by removing it.
Okay. Yeah, because you're not removing the ovary. And so you could, if you had, right. Yeah, that makes so much sense. Yeah.
And this is another question, and I'm glad you say that. Everyone thinks that the little diagram that shows your uterus and your tube's connected to your ovary, it's not. That is not the way anatomy works. Your ovary is there. Your tube is like here. They're near each other. The tube is a fluid thing. It's not attached to your ovary. So I can completely take your tube out and not touch your ovary in any way, shape, or form.
Right, right. I've seen like actual footage of they had caught an egg being released from the ovary before it reached the tube. It was like the most incredible thing I've ever seen. It was so incredible. incredible. I can't get enough of it. That is so incredible. I'm glad you said that though, because maybe we don't think like that. We don't think the way that you are trained to think as a specialist. So I love that you said that and reiterated